In this video, we'll be going over renal tubular acidosis. And the key things to keep in mind with conditions that fall under this category is that they are all conditions that either affect the kidney's ability to reabsorb bicarb or the kidney's ability to secrete acid. If we imagine this as our body's fluid content and there is a happy balance between acid and base that leads to a pH of around 7.4, our kidneys work very hard to try to keep this balance between acid and base. But in conditions that fall under renal tubular acidosis, again, we have trouble reabsorbing bicarb. So if you can imagine, as the blood in our bodies are getting filtered out, our kidneys have an impaired ability to reabsorb bicarb, so all of this gets dumped out, and you have an excess amount of acid in relation to the amount of base you have, thus your pH goes down. Our body also goes through processes that increase the amount of acid production in our body, and usually our kidneys are able to dump all of these out to keep the happy balance between acid and base. But in other forms of renal tubular acidosis conditions, the kidneys lose the ability to secrete acid properly, thus leading to a condition where there is too much acid in comparison to the amount of base that's present, also bringing the pH lower. And with that general concept in mind, we're going to briefly go over the normal function of acid-base management in the kidney, in the nephron of the kidney to be specific, to kind of get an idea of how each of these renal tubular acidoses happen and understand the pathophysiology behind each of the types of RTAs. So first, we're going to start off with a diagram that I'm sure most of you are familiar with the diagram of a nephron. And here you have your glomerulus, followed by your proximal convoluted tubule, your loop of Henle, your distal convoluted tubule, as well as your collecting duct. And the reason why I have highlighted these three areas is that these are the three areas we need to focus on in terms of where the impairments are that causes renal tubular acidoses. Now, for the sake of completion, I'm going to go over what each of these three areas of the nephron does, and then we'll simplify these three areas down just so that we can focus on the essential portions of each of the functions of these three areas that contribute to the overall acidosis. So first, I would like to talk about the proximal convoluted tubule here, and I've drawn out a zoomed in diagram of what happens at the wall of the proximal convoluted tubule here, so the wall here. And just to orient you, this lumen side is where the soon-to-be urine is flowing through. So it's kind of going through here. That's the lumen side. And the blood side, I haven't actually drawn this in here, but this is like the afferent arterial and then the efferent arterial. And this actually continues on and stays along with the nephron and kind of wraps around the tubule here so that the exchange of contents between the lumen and blood is able to continue on throughout the nephron. And what you'll notice here is that the most important thing in terms of renal tubular acidosis to remember about the proximal convoluted tubule is a couple of things. One thing is that this is the major hub of bicarb reabsorption, actually about like 70% or so of the bicarb is reabsorbed here. So you can see here, for example, the bicarb that has been filtered out into the capsule here in the glomerulus kind of flows into the proximal tubule and makes its way down the tube here and arrives here. And as it's kind of interacting with the wall of the proximal convoluted tubule, you'll see that there's this enzyme called carbonic anhydrase, which kind of takes some acid that has been secreted, kind of combines it together to create water, carbon dioxide, and then the carbon dioxide is able to diffuse through, and then the carbon dioxide goes through a reaction with water that's already present in the cell of the proximal convoluted tubule with carbonic anhydrase to produce bicarb. Basically, all of this was done to transfer this bicarb into the cell here, and then after it's inside here in the cell, it's able to be excreted back into the blood. And this acid is being kind of like tossed around and around and around as kind of like a partner for this bicarb to make it into the cell. And this is all to say, for the purposes of renal tubular acidosis, is that it has a function of pulling in bicarb from the lumen into the blood. So next we'll talk about the distal convoluted tubule here. And what's important about the distal convoluted tubule is that this is where we start seeing these alpha intercalated cells. Now, these alpha intercalated cells aren't unique to the distal convoluted tubule. You'll actually see some in the collecting duct as well. But these alpha intercalated cells are important for the pathophysiology of certain RTAs, renal tubular acidoses, because as you may see here, that it is responsible for a lot of acid secretion as well as some bicarb absorption. And if we look at some details here, we see that the alpha intercalated cell actually also has some carbonic anhydrase, just like how the proximal convoluted tubule does, except its source of carbon dioxide is not necessarily taking it from the lumen and such, but taking it from the blood and serving the same function as the carbonic anhydrase here, taking some water and carbon dioxide to create some bicarb and some acid. And it's able to excrete the acid while reabsorbing the bicarb into the blood. Now, if you imagine, for example, your blood is a little bit more acidic than you would like, then what you may do is kind of take some of the carbon dioxide floating around in your blood, use carbonic anhydrase to create acid and bicarb so that you can secrete out the acid and reabsorb some bicarb and to restore some of the balance here. There are some other functions of the distal convoluted tubule, and notably how some diuretics work in the distal convoluted tubule, like thiazides, but they're not as important for thinking about how renal tubular acidoses work, so we're going to forego some of the details for that. The overall function, just to remember for the distal convoluted tubule again, is that it serves for some net acid excretion and bicarb reabsorption. So next we're going to talk about the collecting duct here. And with the collecting duct, we're going to be introduced to some new types of cells. So the principal cell we have here, an alpha intercalated cell, which is the same one from up here, as well as some beta cells that we have here. And with the principal cell, what you may notice that there is no movement of acid, as you may see, or any movement of bicarb. However, there is a big player in the movement of sodium across this channel here, which is regulated by aldosterone, and that will also kind of play into the effect of one of the renal tubular acidoses, which we'll come back to. The alpha intercalated cell is the same one here, so I'll spare you the details, and just remember again, secretion of acid, reabsorption of bicarb. And beta intercalated cells actually do basically the opposite of what alpha intercalated cells do, and they are basically alpha intercalated cells but flipped on its head. So if you imagine this side ended up on this side ended up on that side, that's basically kind of like a beta intercalated cell. This one, as it turns out, doesn't serve as much importance in terms of explaining renal tubular acidoses, so I'll forego some of the details for that. So I know that everything can get kind of confusing with all the arrows and things moving everywhere, so I've parsed down to the bare bones of what we actually need to know about each of the types of cells in order to understand renal tubular acidosis. So in the proximal convoluted tubule, just know that here bicarb comes from the lumen into the cell, into the blood. That's the net effect. In the distal convoluted tubule, we have a net effect of acid being secreted into the lumen and bicarb being reabsorbed into the blood. And in the collecting duct, we have some sodium and potassium movement here that is kind of controlled with aldosterone. And we have alpha intercalated cells again doing the same thing as it did in the distal convoluted tubule, where it's secreting acid and bicarb. At the very least, I think this is the overall schematic that's important to know and understand to get a sense of what's happening in RTAs. So the first type of RTA we're going to talk about is called a proximal RTA. which is also actually called the type II RTA. And the type 2, it's type 2 just because it's the second RTA that had been discovered out of all the other RTAs that we're going to be talking about. And as you may imagine, the proximal RTA is a problem with the proximal convoluted tubule, which means that there is an impairment with the function here of the reabsorption of bicarb. Now, bicarb in our blood, the normal amount gets brought into the glomerulus, gets filtered out, and the unfiltered bicarb remains in the efferent arteriole that tracks along with the rest of the nephron and wraps around like we just looked at earlier. However, the filtered out bicarb makes it into the lumen here, into the proximal convoluted tubule, and that's how we end up with some bicarb in the lumen here. And as we discussed earlier, about 70% of bicarb is reabsorbed into the blood from the lumen to the blood. And what that means is that about 30% of the bicarb remains in the lumen, whereas 70% gets reabsorbed. Now in a proximal RTA, the problem is that the reabsorption is not as well done. So instead of 70% reabsorption, say only 20%, for example, only gets reabsorbed. What that means is that instead of 30% making it through, a massive 80% makes it through to the rest of the lumen here, and which means a large, huge load of bicarb is being brought to the rest of the nephron for the rest of the nephron to deal with. Whereas instead of 70% of the bicarb being reabsorbed, only 20% is being reabsorbed. So you end up with, as you may imagine, less bicarb in the blood, which is less base to maintain the physiological pH in our blood. So we end up with a state of acidosis, and hence renal tubular acidosis. Now, all RTAs, not just proximal RTAs, end up with a specific type of acidosis called a non-anion gap metabolic acidosis. And the reasoning for that is that as we have decreased amount of bicarb being reabsorbed, we have roughly the same amount of sodium still being reabsorbed into our blood. So to account and balance for this positive charge moving through here, usually we have a good amount of bicarb going through. The other one being common electrolyte being about chlorine being reabsorbed into the blood as well. But since we have less bicarb being reabsorbed, in order to maintain the electrostatic balance between within our blood and within the lumen, we need more negative charge moving through. So the amount of chloride that's being reabsorbed actually increases. So if we look at the calculation of anion gap metabolic acid, or anion gap, we have sodium minus chloride minus bicarb. So we have less bicarb reabsorption, but that's compensated for by increased chloride reabsorption. Hence, the anion gap remains the same. And hence, this is a non-anion gap metabolic acidosis. In any case, this large load of bicarb makes it through the loop of Henle, makes it all the way to the distal convoluted tubule, where we see a much greater amount of bicarb here in the lumen, but more importantly, what we care about is more about what's in our blood here, and what we have much less bicarb back in our blood, contributing to the acidosis, so only 20% making it through here in our example, in comparison to the 70%. Now at this stage, what our body's able to do is ramp up some of the function of the alpha intercalated cells. Remember how they were taking some carbon dioxide, splitting it into acid and bicarb in order to recover some extra bicarb here. So this alpha intercalated cell ramps up its function to create more bicarb to account for the difference of, for example, before it was 70% and down to 20%. So it needs to create an extra 50% to maintain the physiological pH. But of course, dumping something like bicarb that's already formed, it's much easier than forming bicarb and then ramping up the process of forming bicarb and creating bicarb to be reabsorbed in the blood. so it can't really necessarily keep up with the amount of bicarb loss. So the creation of bicarb can't keep up with the dumping of bicarb here. Hence, we still end up with an acidotic state even with the contribution of this distal convoluted tubule. A similar story happens here in the collecting duct. We have a lot more bicarb making it down here all the way through. And what ends up here is that the increased negative charge here actually draws out a little bit more potassium and actually less sodium being reabsorbed in the principal cells. And what that ends up doing is we end up with a mild hypokalemia, or it may not even go up to a hypokalemic state, but potassium may be a little bit lower than the person would have otherwise been. In our collecting duct, we also have some alpha intercalated cells doing the same exact thing as in our distal convoluted tubule. It'll ramp up its function to try to restore some of the bicarb to account for the massive amount that's being lost in our urine. However, especially in the acute phase when this pathology just started, the alpha intercalated cells are not enough to account for the amount of bicarb being lost. Now, to summarize, in the acute phase of proximal RTA, I just want you to remember that the dumping of bicarb is much greater rate than creating at bicarb here. So what that ends up with is a downtrending bicarb leading to a non-anion gap metabolic acidosis. We have a slight decrease in potassium due to some of the potassium losses here, being the potassium being drawn out by the negative charge of the bicarb. And lastly, we have a less acidic urine with a pH of greater than 5.3. Now, we just talked about what happens in the acute phase, but in the chronic phase, what happens is that everything is at steady state in the chronic phase. Everything has balanced out. What that means is that because of the downtrending bicarb, this bicarb at the beginning is going to be much less in concentration, which means that much less bicarb gets filtered out into the proximal convoluted tubule. So you have less amount of bicarb here. And again, we still have the impairment of reabsorption of bicarb, but the amount of bicarb being dumped and wasted is 80% of what's filtered. But if what's filtered out to begin with is very low, the amount of bicarb creation later on in the alpha intercalated cells is enough to account for the amount that's being dumped into the lumen. Hence, at this point in the chronic phase, we have the dumping rate equaling the creation rate. So we have a stable bicarb. However, we'll still have a non-anion gap metabolic acidosis, because although this, if you track like the serum bicarb and if it was normal, started getting it acute proximal RTA and then kind of balanced out at this low amount where this alpha intercalated cells are able to account for the loss of bicarb and keep it at this level here. But nonetheless, the bicarb is still low and it's being compensated by chloride, so it still has a non-anion gap metabolic acidosis. The potassium may be about normal or maybe slightly less, but it'll be roughly about the same. And this time, because the alpha intercalated cells were able to ramp up its function and there's less bicarb being dumped down into the lumen to begin with, the urine pH is no longer less acidic. It's normally acidic with the pH being less than 5.3 in the chronic phase. So let me just rewrite all of this here to make it a little bit neater. Now, the other thing I would like to mention is that the proximal convoluted tubule is actually the main hub for much of the reabsorption of basically everything. So there's actually a syndrome called Fanconi syndrome, which impairs reabsorption of things more generally, not just bicarb, where we have the problem of reabsorption of things including phosphate, glucose, amino acids, and uric acid, for example, in addition to bicarb. And because of this problem with reabsorption of bicarb in Fanconi syndrome can also produce a proximal RTA. So if you do have a picture of proximal RTA, you may want to look into whether or not the patient also may have a Fanconi syndrome that is producing the proximal RTA. So next we're going to talk about distal RTAs. And this is also often called a type 1 RTA, again, because it is the first of the couple of RTAs that were discovered. And as you can tell from the name, the distal RTA deals with the distal portion of the nephron, which point to specifically the distal convoluted tubule as well as the collecting duct. And specifically, it's actually pointing to the impairment of the alpha intercalated cells that are found in these areas. And as we talked about earlier, alpha intercalated cells are important in the balance of acid-base physiology in that it is able to create bicarb for extra reabsorption and secrete acid as a result. So if we look at how the impairment in these areas affect the overall bicarb management, we can see that, for example, if we have bicarb again here going into the afferent arteriole, getting secreted out into the capsule, into the glomerulus, and then moving down the lumen of the proximal convoluted tubule, you have bicarb here again. And this time in the proximal convoluted tubule, because it's functioning correctly, we have about 70% absorption of bicarb here, which leaves around 30% of bicarb being dumped into the rest of the lumen for the rest of the nephron here, and making it all the way back up here into the distal convoluted tubule, where you have, again, about the 30% of the bicarb here. And you have the successful reabsorption, about 70% of bicarb into the blood. And what you see here in the lumen side, once we get to the distal convoluted tubule, is that there's no area here for bicarb reabsorption. So everything here actually just gets chucked right out into the urine. Now, we only have 70% of reabsorption in the blood, and we don't want to lose a whole 30% into the urine. So what we do in normal kidneys is the alpha intercalated cells work to close that amount of loss in bicarb by creating bicarb and reabsorbing it. The problem is that in distal RTAs, this function is reduced such that it's not able to account for the 30% loss. It only accounts for much less. And what that causes is, again, a loss overall in the net movement of bicarb from the lumen back into the blood, leading to an acidotic state. And here we'll have cells in the distal convoluted tubule that can account for the loss in negative charge with chloride, as well as when the proximal convoluted tubule starts sensing the decrease in bicarb, and it can also reabsorb more chloride to make up for the loss in negative charge reabsorption. Because again, we have to make sure that we have a balance in negative charge all the time. What this leads to is, again, non-anion gap, metabolic acidosis. And the next thing that we have to note is that this bicarb that's here, it's a negative charge that's being shunted down this lumen. And again, we have to keep a balance in terms of the negative charge. So of course, extra chloride had been able to move across to account for that, so that's good. But the negative charge also is usually accounted for by the positive charge movement of acid and potassium into the lumen. Now, because the alpha intercalated cells are not able to provide as much acid into the urine, a lot of the heavy lifting of providing positive charge to balance out the negative charge of bicarb is provided by potassium. So much larger amount of potassium is being lost into the urine. This overall causes a state of hypokalemia. And as we talked earlier, we have an impairment of acid secretion into the lumen of the nephron. Thus, in the urine is not being able to be properly acidified. Thus, the pH of the urine is less acidic. And when we say less acidic, we mean greater than 5.3. Lastly, one of the big characteristics of distal RTA is the formation of kidney stones. And the reason for that is that we have a loss of bicarb overall because we can't create bicarb for extra reabsorption for whatever's lost in the urine here. So what the body does, what the nephron does, is properly upregulate the amount of reabsorption of bicarb that happens in the proximal convoluted tubule, say from 70% to maybe 80% or so. So it's working really hard to try to maintain bicarb. But the additional thing that the proximal convoluted tubule is able to do is reabsorb another thing called citrate. Now, we haven't been accounting for citrate before, but citrate's also a component inside the blood that is filtered out and can be reabsorbed. And the reason why the kidneys would want to even reabsorb citrate is that in the liver it can be converted to bicarb. So it's kind of like reabsorbing bicarb equivalents. But the problem with it is that citrate was serving an important role in the lumen here to prevent calcium from precipitating out of solution. So usually we have calcium that's hanging around here in the lumen as well, that was excreted out, filtered out in the glomerulus and moving all the way down here and whatnot. And calcium is able to stay in solution because it is in solution with citrate. However, when the citrate concentration goes down in the lumen, the calcium interacts with other anions in the lumen, such as phosphate, for example. And calcium phosphate is much less soluble than calcium citrate, so it is able to precipitate out of solution, causing the accumulation of calcium phosphate stones. And this leads to the production of kidney stones. Now, there are a couple of different sources that can impair the function of alpha intercalated cells, leading to a distal RTA, but one of the most important ones to remember are autoimmune conditions. Some of those include classically rheumatoid arthritis, Sjogren's syndrome, as well as lupus, among others. So the last type of RTA we'll go over is called Hyperkalemic RTA, which is also known as type IV RTA. And what you may notice about the name of here is that it's pretty self-explanatory that it causes hyperkalemia. And this type of RTA is actually one of the more common ones that you'll probably see, in that one of the most common causes of hyperkalemic RTA is diabetic nephropathy. Now, what diabetic nephropathy does is that it decreases renin production. So think of it as an impairment in renin production. What that downstream does to the RAS system is that it decreases the amount of aldosterone. Now, we see the effects of aldosterone here. What aldosterone does is that it upregulates the production of ENaC, or epithelial sodium channels. And this is a very important channel that allows a lot of reabsorption of sodium here to allow for water reabsorption in the collecting duct. So if we were to follow how this impairment here causes an overall acidosis, we can follow bicarb again from the beginning, gets excreted out into the lumen here. Same story as before, bicarb makes it into the lumen, gets absorbed properly into the blood, about 70% or so. So again, we lose that bicarb that moves all the way down, back up. And then throughout the rest of the urine, there's nowhere else to reabsorb bicarb. So same story as before, we lose this 30%. And as we only reabsorbed 70% in the blood, we need to make up for it with the alpha intercalated cells. And this time, the alpha intercalated cells are working properly. However, it's getting impeded in terms of the function a little bit because of the ENaC channel. Now, what happens here in the collecting duct as a result of an impairment, or not an impairment, but a reduction in the amount of ENaC channels due to the reduction in aldosterone, is that you have more sodium relative to normal that's stuck out here in the lumen. Now, what that does in aggregate is that it increases the amount of positive charge relatively in the lumen comparison to a normal state. How that affects the overall function of the collecting duct is that this increased amount of positive charge here affects the ability of other positive charges, such as potassium moving through its channel, ROMK channel, into the lumen, as well as the acid secretion from the alpha intercalated cells. Because it's like trying to stick two magnets north and north together. If you think of magnetism, same thing. If you try to push positive charges towards a place where there's more positive charge, there's more resistance. So these alpha intercalated cells, their function is effectively decreased, more so over here where we have the ENaC channel actually coming into play, but overall function decreasing here, leading to decreased acid secretion and decreased bicarb reabsorption. This, again, causes a state of acidosis that's compensated by chloride in terms of the electrical charge. So what ends up happening is that you have, again, a non-anion gap, metabolic acidosis. And as we mentioned before, because the potassium being let out into the lumen through the ROMK channel, it has a harder time doing that because of the positive charge. There's less potassium being able to be released back into the urine. So what you end up is with a hyperkalemia. And one important thing to note about this is that the reduction in ENaC channel function increases the sodium here a little bit, which does impair acid and potassium secretion. However, it's not to the same extent as when we had an impairment with the alpha intercalated cells. What that all means to say is that although the bicarb reabsorption here and the acid secretion is reduced from normal, it's not that reduced. So the non-anion gap metabolic acidosis is actually more of a mild form. And this is also reflected in the fact that the urine pH is actually able to be properly acidified. So although the function of acid secretion is reduced, the overall function is enough to actually keep the pH of the urine below 5.3. So now as a summary, I've written out each of the key features of each of the RTAs that we went over. And as you may see, each of these may have some defining features, such as the hyperkalemic RTA is the only one with very high potassium, as well as the non-anion gap metabolic acidosis is fairly mild. For distal RTAs, we see that sometimes there are kidney stones produced, as well as it's associated with other autoimmune conditions, as well as the fact that the non-anion gap metabolic acidosis is fairly significant. Lastly, for proximal RTAs, they are oftentimes associated with Fanconi syndrome, which also, as mentioned before, causes loss of things like phosphate, which can lead to conditions such as osteomalacia. But in any case, for proximal RTAs, if you were to give a patient a bicarb challenge, as in some bicarb load, then a significant portion of that will be lost in the urine because the major hub of bicarb reabsorption is impaired. And that is tubular acidosis.